Good morning. My name is Kevin Kirkpatrick from Avery Professional Group. I am here with Josh Steinburg from Healtheon. This is the Healthcare People podcast. So we will be talking about healthcare. We'll be talking about Josh's current role and the work his Healtheon is doing, and how they can add value to physicians and through their practice. So good morning, Josh.
Good morning, Kevin. Thank you very much for having me.
Hey, my pleasure. How about we just start with the simple thing of telling us a bit about Healtheon and what you do.
For sure, I appreciate the opportunity. And Healtheon was born about a year and a half ago now, really trying to understand the pain points of family physicians in Ontario and across Canada, and we really are looking to alleviate those stressors and all the different challenges that family physicians are having with regards to their income, with regards to efficiencies within their office. We want to try and curb the burnout. We want to try and, quite honestly, revolutionize primary care from what it used to be. And in decades, it hasn't changed, and we feel that it's primed for some positive change. For someone to look out for the doctors, for someone to look out for the future of family medicine, and for the 6+ million Canadians that don't have a family doctor. So we really are trying to be that support mechanism for change for the better.
Excellent. So what types of services do you provide the physicians, and how does that translate to improvements for them?
For sure. So at the core of what we're doing, we are, a consulting agency that works with family physicians across the country. We are bringing advanced administrative technologies to the primary care setting. And what I mean by that is we're looking at the traditional block fee model and enhancing that with the technology. So you take the core of what a block fee is for uninsured services, but you tack on an omni-channel ticketing system, which allows patients to communicate differently with the clinic. So rather than just having to phone in to the clinic at 9 o'clock when the phone lines turn on and wait on hold for 20 minutes or half an hour because there's 30 other people calling in at the same time, patients now have the opportunity to send a text message 24/7, send an email 24/7, and the staff will respond at the appropriate time once they're able to sort of triage the incoming requests that are coming from the patients.
Okay. Yeah. So again, it's an access for things that don't necessarily need an appointment and stuff like that, right? So
yeah, it's a combination, right? So the patients are really looking for, what can the clinic do for me? The patient experience, if you will, hasn't been looked at in decades, and no one ever talks about what else can we do for the patient. So we're looking at what can we do for the patient and what can we do for the physician themselves. And we feel as though the technology that we can add to the clinic to allow for an easier communication between the clinic and the patient will help streamline, will help create efficiencies, and will help drive new revenues to the clinic through the subscription model, and through physicians being able to see more medically relevant patients rather than seeing patients that actually don't need to come into the office.
Okay. Yeah, it's interesting. I just received a letter from my GP asking me to pay an annual fee to compensate for prescription renewals, right? Yep. And the challenge is if you make an appointment, he can bill for the appointment. But if the pharmacy calls him, he can't bill for that, right? So it's again, it comes down to utilizing your time better, I guess. And and it's interesting because one of the trends that I've noticed over the last few years is that family physicians are not necessarily working 5 days a week, right? They might be doing OR assist, or they might be doing palliative care, or they might be doing, hospitalist work and stuff like that, right? So, finding ways to communicate with them that aren't arduous is probably a step in the right direction.
For sure. I mean, as you said, physicians are doing other things, and one of the reasons that they're doing, other work within medicine is to supplement their income in a lot of cases, because family medicine isn't what it used to be, and they're struggling with the rising costs, inflation and everything like that, and quite frankly being cut from the ministry in a lot of cases. So they're looking for other ways, and we feel strongly that by sort of streamlining everything that they're doing within their practice through Healtheon, they're able to really streamline and grow their revenues. So not having to worry about other things.
Right. And I think the other aspect that is that, we're seeing their costs continue to go up, right? I belong to a WhatsApp group for physician recruiters, and one of the recruiters today was asking, what an average lease rate is, and it's funny because it's such a wide range, right?
For sure.
And like I've seen $12 a square foot, and I've seen $30 a square foot. So
Absolutely.
there's so many different variables, but the costs continue to rise,
Yep.
right? And like my GP, it was funny, we were talking about this, and like he figures out, because he has a smaller practice, he figures out his expenses are about 40% of his billings.
Yep, I'm
right?
not surprised.
So so it's one of those things where you can understand why there's a notion of, okay, well, we need to generate income for things that don't generate OHIP billings, right? And I get it. And the other option is like I know some physicians that are advocating for no sick notes, right? But until that happens, it continues to be a scenario where they've got to be compensated for it, because it takes time. They've got to look in the chart. They've got to draft the letter and send it and stuff like that otherwise is not paid for. And the big thing is, I think in Ontario they were saying that an average physician can do upwards of 19 hours a week of administrative work.
For sure, absolutely. And one of the things that you just touched on is charting, and charting is a big component of what a physician has to do. It's a requirement, but it's not paid time, right? At the end of the day, whether they're charting during an encounter, right after an encounter, or in the evening, it's potentially hours every day, to your point, 19 hours plus a week of charting and administrative work that they're not being compensated for now. And, quite frankly, when you talked about the physician that has a 40% overhead, that's a large chunk of their income that is going towards overhead. And we can do anything to reduce that to 35%, 30%, 25%. That's a huge difference for that physician and their mentality, their mental health, their work-life balance. And that's what we're trying to do. We're trying to bring new technologies to the clinic so that they can run a more efficient office, reduce their overhead costs as much as possible, and provide optimal patient care.
Well, it's interesting because when I talk to physicians and you're working through their work life with them and stuff like that, you often have to explain that at some point you can only see so many patients and you can only make so much money seeing those patients, that your next step, in all honesty, is cost containment and controlling your costs, right? Like, because at the end of the day, if you can get a maximum roster of, let's say, 1,900 patients, if you can't go to 2,100, then the only way to improve your finances is to spend less money, right? And we're seeing co-locating as a way to reduce costs. We're seeing physicians hire less office staff as well, but those aspects continue to go up as well, right? And the cheapest I've seen anybody do it is probably, I think I knew a surgeon who had his office costs down to 16%, right? But that was a considerably higher billings than a family physician,
for sure,
right? And it's interesting. Like I've recruited some people to PEI, and part of the reason they go to PEI is because it's salaried, right? And there's charting time built into it, right? And here we have FOs, but it's really just a prepayment model. It's not a salary, right?
For sure.
So you aren't necessarily getting paid. You're definitely not getting paid for non-clinical time, right? So it's a challenge from that standpoint, right?
Yeah, and one of the other main components of what we're seeing is that family physicians want to be part of a team, and
Hmm.
unfortunately, they can't afford to hire a team to be in their office.
Yeah.
And one of the other main components of what we're doing is helping them establish team-based care within their office, which is being funded by the subscription model that they're going to be implementing within their practice as well. So what we're seeing is that physicians are able to now hire, whether it's a nurse or a nurse practitioner or an IMG, international medical graduate, or a physician assistant, to be part of their practice and implement team-based care so that they're able to pass on some of the less medically relevant cases to their team so that the doctors can focus on rostering more patients to hopefully curb the unattached patient population, and at the same time see more medically relevant patients which are higher dollar billing codes, which are more relevant, which ultimately helps the positively impact the health outcomes of their patients and their entire roster.
Yeah, and it's interesting because it's not necessarily just a passing on income to the patients, right? It's also a notion of a service that increases the efficiency of communication, increases the right person doing the right thing at the right time. Like my oldest son was dealing with a sore throat, and our family doc's off today, so I couldn't get him in today. So um, I'm like, you know what, I'm going to use Maple,
Yep.
right? And Maple's, it's a great technology and stuff like that. And it was interesting because I met with somebody to talk about him and do the intake, and they weren't a physician,
Right.
right? And then my intake form was sent to a physician who then said yes or no. In our
Right.
case, they said no, they can't see him and he needs to be seen in person. But in other instances, they might say, okay, we'll renew that medication. And what's happening is it's moving people through the system faster and leveraging it. And I think there's two ways to implement technology. And one is physician driven, and the other one is ministry government driven, right? And I think too often we're looking at the ministry driven reporting, basically bean counting technologies to implement it, whereas something like this is a bit more physician focused and a bit more, focusing on what makes their life easier, which is what we need to do, because we're not going to retain physicians if we don't turn it around and start making the work they do easier. Same thing with nurses, right? Nurses are going to continue to leave if we don't improve their quality of work.
You're absolutely right, and I think technology should be a big part of the medical practice today, and it's a struggle to get physicians to implement new technologies, not because they don't want to, but because they can't afford to. The extra $300 to $500 to $1,000 a month for certain pieces of technology that they can implement to make their lives a little bit easier or a little bit more efficient, it will have a return on investment, but that initial sort of feeling of I'm going to have to spend X number of dollars to get to that point, that's where the physicians struggle with. And hopefully that's what we can come in from a coaching and consulting perspective to say, hey, look, these are the technologies that are going to make your practice more efficient. They're going to make your life a little bit better. And this is why, and we're going to help you implement those technologies. Again, for the betterment of the clinic and the betterment of the patients.
Yeah, because too often the complaint is the technology doesn't push a process; it just adds to a process, right? And I think that's the lens that I look at when we look at healthcare tech is who's it actually it's got to improve the patient journey, it's got to improve the physician journey, and it's got to improve whatever reporting requirements are necessary. Otherwise, you're just adding technology for the sake of adding technology, right? And I remember I've probably told this story on other podcasts and stuff. Is my oldest daughter had her tubes in her ears done, and the hospital we went to, she was taken care of very, very well, but they had these Baxter pumps for the IV. Well, the problem is the Baxter pump didn't go into the OR. So you brought them out with an IV and then had to detach the IV and reattach it to this new pump just so you could then use the pump, right? And the nurse was complaining. They're like, you're adding a step in the process to do something that's not really going to improve patient care or improve the nurse's experience. So, it was it was a case of, I think somebody saw a new technology that looked really cool and said, oh, we should implement this, right? Without, what I tell people, and because I work with a lot of physicians, I get a lot of tech companies call me, and the first question I ask is, have you consulted with physicians, right? Who started this process and leading this process? Because if it's a tech guy or something else that they want to take advantage of healthcare costs, I don't always agree that that's going to be successful, right?
For sure. Yeah. I mean, look, at the end of the day, Healtheon was born out of a desire to help physicians and a desire to help patients ultimately.
Yeah.
And we know collectively, our team has over 60 years of experience working with family physicians.
Yeah.
We have a family physician on staff. We have other family physicians as advisors. We have a fantastic team of professionals that are looking to improve the lives of physicians, improve the lives of Ontarians and Canadians as a whole. And we really strongly feel that the service and offering that we have to offer and to assist physicians is game changing. And, it's dare I say revolutionary for family practice, because not enough people are looking at the primary care setting and saying, what can we do about it? There's a lot of, pushing papers from side to side, but ultimately something needs to happen. You got to get boots on the ground. You got to get into those offices and you got to make change. And that's what we're attempting to do.
Okay. Yeah, no, it makes sense, right? And I think, I think that there's a definite need for it. Is there a business case to include specialists eventually in this type of work? Because I don't know, they don't do as much out of pocket services that I can think of off the top of my head, but does Healtheon see that market next, or am I out to lunch?
Yeah, so we're always working with specialists as well. So we have a network of specialists that are going to actually support the family practices in a certain capacity. So we are going to get them involved in the sort of the healthcare journey of the patients, right? Because again, too many times there's 6 months, a year, 2-year wait list to speak to a specialist. And if we can include the specialists earlier on in the patient journey, once there's an unfortunate diagnosis of some sort, we want to be, again, the ones to provide the support to the patients via the specialists to make sure that they're being seen in a timely manner to, again, enhance the patient health outcomes, because they can be seen in a week or 3 weeks or 4 weeks to talk to a specialist about what's going on, about a potential plan. That those health outcomes will improve drastically as opposed to the ones that have to wait 6 months or 2 years. So yes, we're working with physicians in that capacity, and ultimately it probably will spur into, what can we implement from a technology perspective in a specialist to communicate with patients and to communicate with family physicians.
Yeah. Well, because it's interesting. Like I have a good number of physician contacts on X, formerly known as Twitter. And, it's the family docs are complaining because, they send out a referral and the referral comes back denied. Right. And it's not a communication. It's a fax. In a lot of cases, it's legitimately a fax. It says, declined. And
with no explanation.
And then it's like, and it's happened to me too. Like, my daughter needed to see a specialist, and, and I referred her to a specialist that I knew, and, it was declined. Now I have the luxury that I could text him and say, hey, what's going on? And then he explained it and then gave me another physician though. Right. So it wasn't, when you get these referrals back that says no, it's almost like, closing the window in front of that person, right? Like, sorry, there's no. Whereas if you can make the communication more seamless, then the specialist can say, try this person, or
sure.
that opens a whole other door for centralized referrals that we probably need as well, right? But that's the biggest challenges I see within healthcare, both from a specialist and a family practice perspective, is definitely this notion of communication, right? Like I was doing some primary care recruitment for a community, and the family physicians made it known that they wanted to include, like, we do an event for them, right? Like a CME or something. And they would say, can we include the specialists? Specifically because they wanted to build relationships with the specialists in the community, because then they knew who they were referring to, probably could get a cell phone and stuff like that, right? Because some people naively see family physicians as gatekeepers, but really they're like the pilot, right? They're moving your plane through the different processes and through the different relationships and stuff like that. But yet sometimes we don't give them all the tools necessary to communicate well. So I'm a big fan of anything that makes communication for them easier. And, at the end of the day, if it requires some semblance of a fee, then, at the end of the day, I think the communication improvement will outweigh the fee, right?
Absolutely. And communication is key. Being able to communicate in a timely manner with your family doctor, with a specialist, is something that we found, through surveys and the work that we're doing. That's what patients are looking for. They're looking for something that they can control, that they can take ownership of, and say, hey, I want to communicate with a family doctor or a specialist in this way. Up until now, they don't have a choice. It's they call their family doctor, they wait on hold, their family doctor sends a fax to a specialist, it either gets accepted or denied, and then they move on. And in some cases, if it does get denied, they have no one to turn to, and the family doctor has no one to turn to either. Perhaps they can find another specialist, but that's a struggle as well. So if we can open those lines of communication between everyone, I think that's a key component to what we're trying to do, and for the betterment of our healthcare system.
Well, it's interesting because I often find that some GPs that I have relationships with will be like, hey, do you know a nephrologist, or do you know a neurologist or a psychiatrist? Because it's so difficult for them, other than looking through whatever's on their EMR, and however it's locally networked. They don't necessarily know, right? And I did talk to a doctor out of Oakville, I think, who started creating a centralized referral component, but it's really just, a group of, a grouping of physicians. It's not necessarily the same level of sophisticated communication and stuff, right? So I think that's the sophisticated communication that's secure, that is timely, that is, that's easy is what we need, right? So
without question.
Awesome. Listen, so how do people find you? Where's the best way? Are you a LinkedIn guy?
So a little bit on LinkedIn for sure. Happy to talk to anyone. Check out our website, healtheon.ca. Fill out a form. We'll get back to you in a very timely manner. We'd love to speak to physicians. We'd love to speak to patients. We're hoping to be able to create a patient advocacy panel. We have physician advisors on our board as well. We want to, again, communicate. And that's something that, I can't stress enough, is that we want to open the lines of communication between patients, between the physicians, between ourselves, between the ministry, and just make sure that the health outcomes of Ontarians and Canadians is at the forefront of what we're doing, and making sure that there are enough family physicians out there to continue doing what they're doing, because they do great work. They're an essential part of our healthcare system. And if we don't treat them right, we're all going to be in big trouble. So we want to make sure that they are treated right, that they are supported, and we're going to do everything that we can to create a better work-life balance, create more revenue for them, and ultimately enhance the patient outcome.
Excellent. Well, listen, have a fabulous day. Thank you for your time this morning. And if anybody wants to reach out, healtheon.ca, or find Josh Steinburg on LinkedIn.
Yeah,
So
perfect. Awesome.
Take care.
Thanks so much for having me,
well.
Kevin. And we'll chat soon.
Sounds good, man. Take care.